and which particular transducer they will use, and whether there is any role in 20+2 for a TV probe, and what to do in an obese person. All these details, and what is sliding, what is rotating, all these things you can give an introduction to our learners while they are answering the whole questions before Rajat sir starts. I think by 3:30 you should start.
Right. So we have given all the 4 practice guidelines to all our listeners. It is there in the virtual training group. Now, why this 20+, how it came into effect? The thing is, whenever we are doing fetal biometry, we measure, we do biometry in very, very standard plane. That means if I do a scan, I measure abdominal circumference in a very specific way. The stomach should be visible, the spine should be there, three dots, then a segment of portal vein, complete ribs on either side. So this is we speak the same language. So 20+2 planes were designed from these biometry planes, that everybody goes and looks at these standard planes of biometry, and there are more than one structures we can find there, which we have. First thing is we have to know what is normal, and then sometimes when we see abnormality, we know that there is an abnormality. The stomach is not filled in, like the portal vein is not visible, or there is a spinal defect behind the spine, there is a swelling. So the structures will be looking abnormal, and this is, we are not asking everybody to diagnose what it is, but at least it is important to know that this particular plane shows something which is not normal. So going through this 20+2 plane means, this is one plane is we put the transducer, that is called overview. We put the transducer on the and then from there we rotate 90 degrees to go to different segments of the fetal body. Like we go to head. We all know that we are measuring ventricular plane for BPD. Sometimes we also look at a little below where the lateral ventricles are transventricular plane. That is also good for BPD. So both are valid if you do a transthalamic or if you do transventricular. So both the planes are good for measuring the BPD. Then if we rotate a little below, then we can look at the cerebellum, transcerebellar. So this is how we go from one segment to the another segment of the body. And we have to, because those are very standard planes. I mean, the body is so designed that some structures will be looking, we will be able to see those structures very well in that plane only. Like if you want to see the 4-chamber view, we know that when we are sliding from above to below and we come to thorax, we will see 4-chamber view at a specific plane. So all these planes we go in different steps, and then we just see that everything looks normal. If there is an abnormality, what do we do? So either there are two things. When we find something abnormal, I call one of my seniors or my friend that, look at this and tell me what it is. Or if we can't come to a conclusion, then we refer, then we refer the case to a higher center for needful. So this is how these planes were done. And I told you that above the diaphragm, there are 10, below the diaphragm there are other 10. So, and then the next overview was a sliding slide from head to right up to the buttock, and then again rotate 90 degree to look at the femur. So I think when we come on site to you, we will definitely show each and everything that how you can, how much you have to rotate. You know, I think last time we had discussed about fetal biometry. Every plane was described very well. And then we also had the information given to you, everything. So about the movement of the probes, it has also been told that there are only three movements. First thing is a rocking movement. The transducer we rock, right? Everybody knows what is rocking, a rocker, you know. And another is a rotation. So like it is this way, then we go to mid sagittal. So this is a rotation. And the third movement is the sliding movement. We go down very, very slowly. The sliding movement is very important in the sense that we just don't swiftly slide down. It is to be done very, very slowly. Sometimes we also use angulation. Like I have put my probe, we just showed you that how do we look at the lie of the baby? What is the presenting part? So we told you that you would just put the transducer horizontally on the symphysis pubis and then look at what is the structure which is showing that. If there is a head, it will be cephalic. If there is a buttock is showing, it is breech. If nothing is showing, it is likely to be a transverse lie. So these are the very, very typical steps we have to take to do a very, very good diagnostic imaging. And also, whatever is the lie, we all know that because heart is in the middle. So at the mid abdomen, you will always find the heart. So what happens is now, let us decide by doing these scan, these 20+2 planes, if we are very, very carefully looking at everything, we can diagnose at least minimum 50 abnormalities, minimum 50. Like when we are looking at the heart, let us say there is no, no heartbeat. So we know that, okay, there is, the fetus is no more living, right? So this is how we have to, and the lie is very important. We have to know how the fetus is presenting, which side is the spine, fetal spine, relation to maternal spine. So this is how, if we do things in a very, very standard format, we come to image the fetus entirely, and in this mid-trimester scan, at least 50 abnormalities we can detect. So I think rest I leave to Dr. Rajat.
And shall we give some more time for pre-poll or shall we end it? Sambit sir.
Madam,
do you want the
Madam, 43
questions to end? Participants, you want some more time to attempt the pre-poll questions? Anyone? Deepak Tripathi, Prakash, do you want some more time? Have you finished up? Don't click on end poll. We'll give them 5 more minutes. Only 60% have participated of 71. Please participate boldly. Even if it's wrong, doesn't matter. See how your okay. And each of the questions after your post poll, each of the questions will be discussed in detail by Dr. Hasmukh sir and Rajat sir. Okay. Feel bold. Go. Should increase.
गाड़ी खुलिकी से जो तारो दीटा तारो अछि बडल
कोन है ये तारो गाड़ी को तब वार्ता करछि
କାର୍ଟୁନଟା
ଏ ତାର
ରଖିବ
ଗାଡି କଥା କହୁଛି, ପ୍ଲିଜ
ଆଉ
ମ୍ୟୁଟ କର,
ଗୋଟେ ଏବେ ଆଣିଥିଲୁ
host please mute everybody
ଚେକ୍ କରିଦେବି ସେଟା
in the
ସବୁ
speaker,
ରଖିଦବ ମୁଁ ଠିକ 4টাରେ ପଳେଇବି କ୍ଲାସ
mute
ଯେତେବେଳେ
kar
ଯାଉଛି
mute karo, kon aadu sodu guda subuchi kotha. Tamane au ke answer karunanti, shall we end the polls? And we'll have Rajat sir starting. 61% attend kale. Poll end kari deba samaste participants, please.
मैडम
Yes, sir.
स्टार्ट करिए
Himanshu Das, Deepak Tripathi, Pranati. Come on, feel bold and go on answering, go on attempting it. Then after the session, you will feel nice when your knowledge has increased, and you alone will know your own score. None of us will be able to know what has happened. Okay, this has been designed in such a way, so feel bold. Nobody, you will not be identified. Ashok, attend kar sarlani. Poll questions, Ashok Das from Kalahandi, I think. Bhavani Patna, Ashok, answer kar sarlani. Karo, feel bold. Yes, it's going to be very helpful, Shrikant. Yes, indeed.
Thank you.
Because I myself learned so much when I was going through the slides. Hats off to Hashmukh sir. So much I have learned, and how to be careful. Many of the rotations and slidings I myself was not doing. So it is very, very, it is such a great occasion for entire states specialists to get this kind of quality training of international standard. Really, it can be only Lord Jagannath's grace and nothing less than that.
मैडम ए जो हमरो आमे चार्ट टा जो देशु मेडिस्कैन रो they are standard images actually, not that it is a rule of threes we are not adopting in ISO.
Yes.
Rule of three was to look at the fetus at three different, like coronal, transverse and axial, but whichever
doesn't
way
matter, the images are standard.
Yeah,
and
those are the standard images we have to preserve. At least we have to look at, because most of the anomalies, like ISWOG has one reporting format. I think every image which is required there is shown here. There is a mid trimester. I think I will again post.
I think we should start. Huh? Sambit, let's end the polls.
Okay, madam.
End the polls. Now we start with today's session. The mid trimester scan 20+2 planes.
Madam, apana Rajat sir introduction.
Yes.
Yeah, okay.
We have none other than Professor Rajat Rai, and I'm telling you, he's a self-made man, and I really admire his zeal of progress, and he has gone to the top almost in his profession. He's professor, head of the Department of High-Tech Medical College, Rourkela, and he's also the director of Ray Hospital and Test Tube Baby Center. So we in Rourkela, Manu Patnaik was the first who started Test Tube Baby, and of course Rajat's quality of service is also very, very good, and he's at present the president of IMA of Odisha State, and he was national vice president of FOGSI in 2018. He was national executive body member of Society for Fetal Medicine in 2015 to 17. Then Indian Federation of Ultrasound in Medicine and Biology national executive member, and again of ISAR in 2014 and 18, and he was governing council member of ICOG in 2015 to 17. He's done diploma in advanced gynae laparoscopy in France. He has fellowship in cosmetic gynecology, American Board, and trained in infertility in Singapore. And there's no end to it. So we are very, very happy. He was once upon my student also. And just like बाप से बेटा ज्यादा, teacher से student बहुत ज्यादा हो गया है. So welcome Rajat. We are very happy to have you with us as one of our trainers. And let's give him a big clap. He had a candle light march for Archana Sharma, who recently died, but I don't subscribe to her committing suicide. None of us should be as weak as her. We should be strong and fight together. We are with each other, and we doctors should stop talking against each other. So with that note, I welcome Rajat sir. Please start sharing your screen and present your topic. And all of us, you must listen very, very carefully. And you'll be happy to know what your knowledge will, how your knowledge will increase, and how your post-poll answers will be much better. Your own score will improve. It's an extremely important topic. Can we have a full screen, please, Rajat? Slideshow.
Thank you, madam, for the nice words. You are my teacher, and with your blessings of yours, I could get so much knowledge. With this, I am now going to start the 20+2 plans and midterm scan.
Can you make it full slide, Rajat? Full slide.
I have made it full slide, madam.
Slideshow. We can see your slides, but make it a slideshow. So
I had made it a slideshow.
Okay, but we are not seeing slides. So we are seeing your on the left side. We are seeing your other slides. So
go to the bottom.
No, I had made it in my screen, but it is not visible to you.
No, we can't see slideshow. We can see the side
Now,
PPTs also.
Now also. Can you see the change of slides?
No.
No, slides are not changing. Just select slideshow.
I had selected one.
आउथरे लॉगिन करबा पड़ियो बोले आउथरे आपण ये करन
आउथरे शेयर स्क्रीन करले हबो
मैडम सर नेटवर्क इशू थिबो नेटवर्क स्लो थे
नेटवर्क
स्टॉप शेयर करके आउथरे शेयर कर लगे
स्टॉप शेयर कर जाते कर से पण डाउन स्लाइड सब स्टॉप शेयर कर कौन करेंगे शेयर स्क्रीन Network is moving, no?
We can see your slide, but no, okay, start with that. You can, slides are not moving actually.
Now
you can
also.
see your first slide.
Madam?
You can see your first slide. You are audible. We can
Madam,
see your, just
can
move
you see my slides are moving, changing?
No, not moving. You can see the first slide. The second slide with Lord Jagannath is not visible on the screen, main screen. Will Sambit, can you present? Let's see if Sambit can share and you can see your own slides in your screen and talk. Okay, Sambit.
I have a lot of videos actually. So if it is not possible, we will tell the screen now.
कौन है कहीं असुविधा होती
सर वीडियो को कोन आपण लिंक सर को इंटरनेट अनस्टेबल थियो बोले वीडियोटा लिंक रे अछि ना अलगा जगह रे अछि
ना वीडियोटा इति अछि लिंक रे अछि
माने आपण लिंक करछंती की ए जो पावर पॉइंट प्रेजेंटेशन रे सर लिंक करछंती की
ना पावर पॉइंट डायरेक्ट पर अछि लैपटॉप रे डायरेक्ट अछि
ए जोटी वीडियो सर देखाइबे से वीडियो रे पावर पॉइंट रो लिंक रखछन ना से अलगा जगह रे अछि
ना पावर पॉइंट हमर एडी माने तयारी करजे लैपटॉप रे तयारी करजे लैपटॉप रे सेट प्रेजेंट करजे डायरेक्ट
এটা आपण शेयर करबा पड़िबो सेटाको आपण स्क्रीन शेयर करबा पड़े प्रथम रे ओपन करंतु आपणकर स्लाइड शो ओपन करके तापर शेयर स्क्रीन रे पकाइबे सेटा
এটা সুবিধা কি আরটা সুবিধা কেনটা সুবিধা
अच्छा, let's see if Sambit can make it slide. Sambit, share कलो देखिबा.
मैडम करू
से आपण प्रेजेंटेशन सिना शेयर कर देबे किंतु
नहीं वीडियो रा परे देखिबा, वीडियो परे देखिबा.
हां प्रेजेंटेशन तो विजिबल थिला मैडम
नहीं प्रेजेंटेशन रे स्लाइड मूव करनी परा.
ओ,
स्लाइड तो
slide
मूव करूनी.
आगो प्रेजेंटेशन टा को ओपन करके तापर से व्यू करिया पे कोन तुमर
ऑथोरिटी शेयर स्क्रीन करी चेष्टा करो. ना लेट संबित तमे टी शेयर करो.
आगे मैडम
जोठी वीडियो थिबो we again Rajat can show us.
आगो सर प्रेजेंटेशन टा ओपन करंतु तापर शेयर स्क्रीन करन
Rajat, open your ये video, open your slide, make it slide show तापर share screen.
हां एबे सर ओपन करले
बस लगी
हां स्क्रीन टा आपण देखो जाओ प्रेजेंटेशन टा ओपन करो तो
प्रेजेंटेशन ओपन कर आसुनी
नहीं आपनकर येटा आसी माने कंप्यूटर व्यू टा आसी प्रेजेंटेशन तो आसुनी आपण सर प्रथमे प्रेजेंटेशन टा पूरा ओपन करो एटा क्लोज करंतु शेयर स्क्रीन बंद करन
अच्छा प्रेजेंटेशन पर ओपन स्टॉप शेयर करो
आगो आपण प्रेजेंटेशन टा ओपन करन
Presentation open करो.
हां एबे फुल स्क्रीन करन तो
फुल स्क्रीन ये फुल स्क्रीन हो
Slide show कर देले full screen है जो.
हां
Slide show को आसो.
बस लगी मैडम
नहीं तो
नहीं slide show जोटी अछि सेटा सिलेक्ट करो.
अन्ने करली मैडम से कले करूची जे
ठीक है तळे जोटा अछि ये बढ़िया ट्रफ बढ़िया.
से जो कप बलिया अछि रे क्लिक
क्लिक
करन
करो. हां बस फ्रॉम बिगिनिंग करो.
आसिला मैडम
ना
चलो
बस
क्लिक करो. बिगिनिंग टा क्लिक करो.
बिगिनिंग
ହେଇଛି କ୍ଲିକ୍ ହେଇଛି କ୍ଲିକ୍ କରିଛି ତାଙ୍କ ଆସୁନି
चेंज करो स्लाइड चेंज करो एटी
हेलो डॉक्टर संबित आपण कर दियन देखा जाऊ कोन अछि
ये देखो जोड़ा खुले चले
या
हां एबे
आसला.
स्लाइड चेंज होची की नहीं
होची
दियो.
चेंज करन तो स्लाइड गोटे
स्लाइड चेंज होनी स्लाइड चेंज
हबो सर टिके टाइम लागिबो हबो करन
खाली क्लिक कले हबो न नहीं तळकु से जो एरो कले हबो.
हां स्लाइड टा चेंज होनी
हां
यस
चेंज होला ना
हां आसी गले जगन्नाथ.
जगन्नाथ बचेले
हां ये वंदन सब. अरे तांकरी काम एटा तांको स्टेट को हमें सबटु टॉप को नवा हम कंट्री रो.
respected my remote teacher Professor Sama Kanungo, respected hospital class sir, respected seniors and dear friends, I'll be presenting today in the mid trimester scan with special emphasis on 20+2 planes approach by ISUG. What is the objective of a scan? Now it is visible, na?
Yeah,
Yes,
now
yes.
it is visible.
Slides are moving. Very good.
So to predict with confidence the structural normalcy of the baby within reasonable limits of expectation. Mind the word within reasonable limits of expectation, to identify severe and lethal anomalies and to raise the suspicion of an anomaly which would warrant further testing or serial scans. This is the main objective of a mid-trimester scan. So we start with the history of the patient. From the history, we know whether the patient is a high-risk patient for anomaly or low-risk patient for anomaly. But mind you, even if she is a low-risk patient, we still get anomalies. We will not think that she is a low-risk patient, will not get anomalies. And third and most important thing, what the mother wants. Suppose the mother comes tells that my first baby is a Downs baby, and she expects you to tell that you are excluding Downs by doing a mid-trimester scan. So you must explain the limitation of ultrasound at the mid-trimester to exclude Downs syndrome. So with these basics, we will start the ISUG basic training, 20+2 plans approach to the routine mid-trimester scan. Dr. Hasmukh sir has already described how it is devised. So what is the learning objective? At the end of the lecture, you will be able to explain how to perform a structured routine examination, including measurements of the mid-trimester fetus using the two overview and 20 plans approach. These are the main ISUG slides which I picked up from the net, which are Hasmukh sir has sent to me. So I will present the original slides. Along with that, I will present my videos. The key questions will: what is the rationale behind the 2 overview and 20 plans approach? What are the 20+2 plans? How do the plans relate to the ISUG basic training recommendations? And what anomalies should be excluded when the 20+2 plans approach is performed correctly? What is the rationale? It is to provide a structured and logical method of examining the mid-trimester baby by performing an anatomical review within the anatomical planes from which you obtain the fetal biometry that also has the potential to exclude 50 fetal anomalies or abnormal appearances. The basic biometry which you do in the mid-trimester are 4: biparietal diameter, head circumference, abdominal circumference, and femur length. So what are the 20+2 plans? A combination of 2 overviews, 2 sweeps and or 2 overview sweeps and 20 plans of the fetus. Each of the plan relates to a specific fetal section or view. Measurements are to be taken wherever necessary. Each plan has a number of structures to be evaluated. Criteria for the referral are included. A combination that enables the potential exclusion of 50 abnormal fetal appearances. So how do these recommendations have occurred? They have taken several guidelines of ISUG, and taking all these guidelines into the consideration, they have devised this 20+2 plans approach. So what are the 20+2 plans? It is divided into 7 anatomical area and 2 overviews. Each anatomical area has some plans. The first is a overview sweep or sweep 1, where we do a survey scan by seeing the longitudinal head and body for initial orientation of the baby. Then we come to the planes. First plane is a sagittal complete spine with the skin covering. Second is coronal complete spine. And third is the coronal section of the body. As we go on, we'll show this in slides. In the head, then we come spine. Second anatomical area is the head. We come to head, where we see the 3 planes: transventricular, transthalamic, and transcerebral plane. Then we descend down to thorax, where are the 4 planes we are seeing. Lungs, 4-chamber view of the heart in one plane. Next plane is the left ventricular outflow tract. Next is the RBOT and crossover of LBOT and pre-vessel trachea view. Then coming to abdomen, again we have 3 planes in the abdomen. Transverse section of the abdomen with stomach and umbilical vein, upper abdomen. Mid abdomen we see a transverse section of the abdomen and cord insertion. And lower abdomen we see the transverse section of the left kidney and pelvis, right kidney and pelvis. Then we come to pelvis to see the transverse section of the pelvis, bladder, and both umbilical artery. Then we move our probe to see the limbs. First to start with the femur, to measure the femur length. Then 3 bones of both legs, both feet, and normal relations of both legs to the foot.
Excuse me.
3 bones of both arms, both hands, and normal relationship to both arms.
Unmute all except the speaker. Unmute.
Coronal view of the upper lip and nostrils, both orbits, both lenses, median facial profile, and we end by checking the last sweep or last overview sweep 2, where we take a transverse sweep of the body from neck to sacrum, 1 vertebra at a time. You take the vertebral transverse section at a time. from head to toe. So this anomaly scan covers from head to toe all the structural anomalies. What anomalies should be excluded? The key to the 20+2 lens approach is to understand the importance of knowing what's the normal ultrasound. We'll go to what the normal ultrasound appearances are in each plane. So then when you see some structures which looks abnormal, we may consult our friend, our senior, or we may refer to a hair center. The knowledge equates to the exclusion of a range of abnormal appearances and or anomalies rather than making a diagnosis. The range of abnormal appearances being sought may differ depending upon local service requirements. So we come to the direct. First is the sweep one, which is the longitudinal head and body for initial orientation. We place the probe. This is the sweep one. From that, we place the probe, and we from the probe we start from the symphysis pubis, go up to the fundus, and from the move probe side by side. From that, we ascertain where the spine is, where the head is, where the body is. From that, we have a initial knowledge of the baby. They call it survey scan. We are seeing a sweep scan where we are getting a gross idea of the baby. Here in this case, cervix breach is near the cervix. It is a breach presentation with a good amount of liquor with functioning heart. Means it is a live fetus with placenta not low lying. We have a gross idea. Again, we can have know the number of the fetus. Suppose in this case, we are seeing there is a membrane in between. We are seeing 2 fetuses. So it is a multiple pregnancy. So in this survey scan, what do we want to know? We want to know the number of fetuses, lie and position of the spine, viability of the fetus, some knowledge about the placenta, and knowledge of the amniotic fluid. Then we go to see the cytos of the baby, where we take the longitudinal head and body for the initial orientation. From that, we take a mental picture by placing ourselves in the baby's position, and we know the left side of the baby. Where is the left side of the baby? And that left side of the baby should correspond to the stomach and apex of the head. So it is a normal cytos. If it is opposite, it is cytos inversus. And if it is, suppose stomach is in left side and apex of the head in the right side, or vice versa, we call it cytos ambiguous, where maximum anomalies can be seen in cytos ambiguous. And there is a simple formula. If it is baby in the longitudinal lie, if it is in cephalic presentation, there is a or breech presentation, then we take 3 points. They take spine, stomach, and portal vein. It should be in clockwise if it is a cephalic presentation. Or if it is a breech presentation, it should be anti-clockwise. Here the baby is in breech position. We are seeing spine, stomach, portal vein in anti-clockwise. It is a very simple formula if the baby is lying longitudinally. But if the baby is lying transverse or oblique, so mentally make up the picture how the baby lies. From that, you ascertain where the left side of the baby is. Then we will go to the planes. First plane is the sagittal complete spine with skin covering. So we move your probe on the back of the baby. We want to cover from head to the sacrum. What are you seeing? We are seeing 3 lines. One is skin line. This is the skin line, intact skin line throughout. Then we are seeing the first is the one ossification center of the posterior lamina. Next is the ossification center of the vertebral body. So it looks like a tram line. It is parallel in thoracic and lumbar regions. In cervical regions, there is a little bit of widening, and in sacral region, there is a tapering with small upward tilt. So this is a normal spine in sagittal section. During this section, we also have to look at the neck. The neck normally appears as a cylindrical with no protuberances, masses or fluid collections. So obvious neck masses such as cystic hygromas or teratomas should be documented at this stage. Then we go to the second plane, that is a coronal complete spine. So how do we come to coronal? All these movement of probe are easy, just to think of how to come. Once there is a baby is in sagittal position, you want to come to coronal. So you have to angle your probe through 90 degrees. It is as simple as that. So plane 1 to 2 angular probe through 90 degrees. So start with sagittal section. Then you move your probe to 90 degrees. Then try to see the coronal section. From neck region, you go from the neck region, there is a cervical widening. Then you go down, down, down till the sacrum. So what are you seeing coronal region? Two ossification centers of lamina. Their echogenic areas parallel to each other. Ossification of center of the vertebral body is seen in the middle. There is a physiological widening in the cervical region, as well as there is a physiological widening at the lumbar region, and there is a convergence at the sacral region. Then you come to plane 3. Again, from plane 1 to plane 3 is a coronal section of the body. Again, we have to move the probe at 90 degrees. So plane 1 to 3, angle probe through 90 degrees. Start with plane 1, that is sagittal section. You move your probe at tight angles. You can see the coronal section of the body. Now you can see the coronal section of the body. Then we are coming to second anatomical area, that is the head. That is planes 4, 5, and 6. So we were here, 1 or 2. Then we are moving to head. Plane 4 is the first plane, that is the transventricular plane. Again, how to get the transventricular? That is the transverse section of the head. So from the sagittal section, you moved at 90 degrees. So if you move at 90 degrees, you will get the either sagittal or coronal section of the spine. You go to the head, cross the neck region. Just after the neck region, you move your probe at right angle. So you will get the transventricular plane. You are getting transventricular plane. So what are the structures you are going to see in the transventricular plane? You are going to see the skull size, shape of the skull, which is usually elliptical. Integrity of the skull, it is almost complete in all sections. Beside the suture areas, there is no deficit in the skull outline, and the density of the bone, it should be echogenic. And if there is echogenic, what will happen? First, near half of the skull, half of the brain will have a reverberation artifact. So the far away half will be more clear in comparison to the nearer half. So if it is not ossified properly, so both the halves will look similar. And you can compress the head also with your probe. And you are seeing the midline facts. Anteriorly, you are seeing the cavum sternum pellucidum, which is the deficit in the midline facts anteriorly, which is square separated or triangular separated box. Then frontal or anterior horns, then posterior horns of the lateral ventricle. And you measure the posterior horn of the lateral ventricle at the level of occipito-parietal sulcus. This is the occipito-parietal sulcus. You measure at this level from inner to inner, which should be maximum limit should be 7 millimeter at this mid trimester scan. 10 millimeters at this mid trimester scan. Transventricular. So once you have finished the outer area, so what you are measuring, always you are measuring the further lateral ventricle. So if you are measuring, you should not ignore this nearer ventricle. So you have to, how you will see, you will move your probe little bit do angle, try to see through this suture. You can see the nearer ventricular disease, just eyeballing, you can rule out any ventriculomegaly. So I have moved my probe laterally. And you can see the nearer lateral ventricle, which is where the correct plexus is strongly fitting in inside. So there is no ventriculomegaly. Then the plane is transthalamic plane. From plane to
Our slide have disappeared.
Screen वाला कहेंगे slide
Sir,
sharing
on.
कौन देगा लगाए?
Sir, maybe stop share screen say switch click
Oh.
author sir share screen.
Avthare karantu.
ଆସିଲା ନା
हाँ
ଆସିଲା
असला ते full screen नहीं, full screen नहीं.
Sir presenter view रे नहीं. Then sir say right रे जो
ଏଇଥିରେ ଏଟା ସ୍ଲାଇଡ୍ ଚେଞ୍ଜ ହଉଛି ନା ଏଥିରେ
हाँ sir
Slide change होଉଛି କିନ୍ତୁ video
ମୁଁ ଏଇଟା କରୁଛି ମ୍ୟାଡମ୍ କଣ ଅସୁବିଧା ହଉଛି ସେଟା କିଛି ଗୋଟେ ଅସୁବିଧା ହଉଛି
video
sir lower panel ରେ जो ଅଛି sir
ନା
lower panel ରେ जो book
ସେଇଟା ହେଲେ ବେଳେ ବେଳେ
symbol
ପ୍ରୋବ୍ଲେମ
ଅଛି।
ଏଇଟା କଲେ କିଛି ଦେଖା ହଉଛି ତ କ୍ଲିୟର ଏଟା ଦେଖା ହଉଛି ନା କ୍ଲିୟର
Recording in progress.
From plane 4 to 5 rotate and slide minimally. Plane 4 to 5 rotate and slide minimally. So from transventricular to the transthalamic. So what I'm saying, I'm rotating and sliding minimally to get the transthalamic plane. So now you are getting the transthalamic plane. So in transthalamic plane, so this is the plane where you measure the BPD or head circumference for the biometry. Where again see the midline flux. If two halves will be equal, it will be midline. Anteriorly, we are seeing the capitulum callosum. Posteriorly, we are seeing the two thalami forming almost an arrow sign, pointing towards the occiput. So in you measure the BPD and SC in this level. The ideal angle of insinuation is 90 degrees to the midline echoes. If when you are measuring the BPD or head circumference, this should be in midline. This should be 90 degrees to the beam. Symmetrical appearance of both hemispheres. Continuous midline echo of flux area broken in the middle by cavum, septum pellucidum, and thalamus. And you are not seeing the cerebellum in this picture. So it is a proper transthalamic plane. When we are measuring the head circumference, we are taking the outer circumference of the bony area, total outer circumference. Whereas when we are measuring the BPD, we are measuring from outer of the near calvarium to the inner of the further calvarium. Then plane 6, the transcerebellar plane. Again from 4 to 6. Means from transventricular to transcerebral plane, you have to rotate your probe. Slightly rotate your probe, you will get the transventricular plane. Transventricular to transcerebral plane. So I am rotating my probe. So I am getting the transcerebellar plane. So in this plane, what you will see? You will see the two cerebellar hemispheres making a dumbbell separate sign. In the middle, there is a echogenic structure called vermis. Behind the vermis, this space is called cisterna magna. Behind the vermis, to the occiput, this space is called cisterna magna. And from out of the occiput to out of the skin, this is the nocal skin fold thickness, which you measure in the mid trimester at this level. Then we come to the next anatomic plane, that is thorax, plane 7, 8, 9, and 10. Plane 7 is the lungs, four-chamber view of the heart. How will you get that? Simple. Again, from the spine, you take a 90 degree, you will get the transverse section of the thorax. So plane 1 or 2 to 7, rotate through 90 degree and minimally slide so that you get the proper plane. So you are seeing the four chamber and the lungs at this level. So what are seeing? Two lungs on both the sides. In middle, there is a heart. So all of them roughly occupy 1/3 each. Heart occupies almost 1/3 of the area. Then you can see the fourth chamber in the color also, filling of the fourth chamber. There is no defect in the interventricular septum. In axial section at the level of the heart, there is a hypoechoic lungs embracing the cardiac area 1/3 each. Both lungs should be appear homogeneous without evidence of any mediastinal shift or any masses. In fourth chamber, what you are seeing? You are seeing the atria, the spine. So this is spine. Nearer to the spine is the left atrium. This is the right atrium. Left atrium to left ventricle, right atrium to right ventricle. You just remember nearer to the spine is the left atrium. And both the atria will be of the same size. Left will be closer to spine and contain foramen oval valves. You can see foramen oval valves pointing towards the left atrium. So it always opens towards the left atrium. There is an interatrial septum with interruption due to foramen oval valves. You look for the, in real time, you look for the movement of the atrioventricular valves. So here is the mitral valve and the tricuspid valve. Look for the movement of the and in ventricles, they will be approximately of the same size. Right will be more rounded and has a moderate band. You can see the apex of the left ventricle is empty, whereas in the right ventricle, there is some echogenic structure waiting. So that is the moderator band. And you can see the intact interventricular septum. What is more important, you see the crux here. It is formed by intraatrial septum, interventricular septum, and two AV valves. This forms the crux. And if you keenly mark, if there is a space, there is a gap between the mitral valve and the tricuspid valve insertion. This is called the offset. So they should not insert at the same level. There should be a gap. Tricuspid valve is more towards the apex of the heart. And if you measure the size of the heart, already I have told. If you are taking a line from mid thorax from the spine to the anterior wall, another line we are taking through the interventricular septum, that forms the axis of the heart. It is roughly 45 degree plus minus 20 degree to and always towards the left. And you always show the rhythm of the rate and rhythm of the heart, if it is regular or not, and the rate of the heart also. Then plate 8 is the left ventricular outflow tract. So plane 7 to 8 rotate towards the right shoulder because the aorta goes towards the right shoulder. So you just rotate your probe from 4 chamber towards the right shoulder, you will get the aorta. In real time, you look for the opening and closing of the aortic valves. And if you mark, there is a continuity between this aortic wall. One wall is continuous with this intraventricular septum. This is called septo aortic continuity. And another wall is continuous with this mitral valve. So if it is continuous, you are ruling out BSD, membranous BSD, and other anomalies. And you can see always have you put on some color to confirm the any color flow abnormalities. Then plane 9 is the RBOT or right ventricular outflow tract and crossover of LVOT. So how to get that? Again from plane 7 to 9, just slide towards the head. You go transversal slide towards the head, you will get this 4 chamber view, RBOT. This is 4 chamber. So you are getting this RBOT and the crossover. Means it is a cross section of the aorta and the longitudinal section of the pulmonary artery. This is crossover. So means they are not in directions. So the still picture you can put on color also to see. So this is the aorta and this is called circle sausage appearance, short axis view of the right RBOT. You can see LBOT, there is no branch, but you can RBOT, you are seeing there is a branching. There is a branch. So you compare the LBOT, there is no branching, whereas RBOT, there is a branching. Then plane 10 is a 3 vessel trachea view of the heart. Again, plane 9 to plane 10 slide towards the head. So from the RBOT to 3 vessel view, just slide towards the head and you are getting 3 vessel view, 3 vessel trachea view. RBOT and you are getting 3 vessel trachea view. There are 3 vessels and trachea. 1, 2, 3 and trachea. So what are the 3 vessels? This is a pulmonary artery containing as a ductal arch, this is the aortic arch, this is the superior vena cava, and this slit-like portion is the trachea. From size-wise, it is from left to right, and size-wise, this is the largest, then this is the second one, this is the third one. And from left to right also, this is the leftmost, this is the middle, this is the right. And it is the apex of the V is always towards the left of the trachea. And if you put on color, the flow of both these should be in the same direction. So it is the opposite side, spine is upper, so the flow is toward the same direction. So then comes the plane 11 to 14, that is the abdomen. From thorax to abdomen, where you are shifting, you just have a look at the diaphragm. And you can see both in the sagittal section as well as in the coronal section. When you are seeing the stomach and heart on the both sides of diaphragm, you are ruling out most of the cases of CDH, congenital diaphragmatic hernia. This is plane 11, that is the transverse section of the abdomen with stomach and umbilical vein. So plane 10 to 11, you just slide from 3 vessel trachea view to stomach and abdomen. You just slide your probe transversely and you will get the stomach and abdomen. So this section is the section for measuring the abdominal circumference. You take a transverse section of the fetal abdomen as circular as possible. Umbilical vein at the level of the portal sinus making a hockey stick appearance. Stomach bubble is visualized towards the left. And behind you should not see the kidneys, rather you will see the adrenals. And you always measure including the skin, out of the skin. Plane 12, then the transverse section of the abdomen and the cord insertion. The next plane from 11 to 12, again you just slide, you will get the cord insertion side. And you are getting the cord insertion. So this is the, why it is important. When you are seeing a cord, there is no defect in the abdominal wall near the cord insertion. You are ruling out two major anomalies, umphalocele or gastroschisis. Plane 13, transverse section of the left kidneys and pelvis, right kidney and pelvis. So from 12 to 13, slide plus minimal rotation, you will get the kidneys. From umbilical cord insertion to the kidneys, you have to slide and make a minimal rotation. This is the umbilical cord. From here to slide and get the minimal rotation, you are getting two kidneys behind. So you measure the kidney in transverse section. You also see the kidney in the sagittal section, coronal section, to if you are suspecting an anomaly. And you always measure the pelvis of the kidney in the mid trimester. Always it is measured in the transverse section. So it should be maximum limit is 7 millimeter at this mid trimester. If you are suspecting or not seeing able to see the kidney, you can take a coronal section and put on the color. You can see the renal vessels, renal arteries traversing the kidneys if the kidneys are present. If the kidneys are absent, you may not see these arteries. You will not see these arteries. Then transverse section of the pelvis, bladder and both umbilical arteries, that is plane 14. Again 12 to 14, you slide. 12 means cord insertion to 14, bladder. You just slide, you will get the bladder. Bladder with two umbilical arteries. If you are seeing two umbilical arteries, you are ruling out single umbilical artery and you are seeing the bladder, dimension of the bladder. Whether it is distended or not, you can rule out. Then comes the limbs, that is planes 15 to 17. First is the plane 15, that is the femur diaphysis length. So from plane 14 to 15 means bladder to femur. How will you go? Obviously, we will slide and rotate because the baby keeps on moving to get the femur. So here the bladder, from bladder, you are rotating and getting the femur. And this is the plane where we measure the femoral length for biometry. The FL is imaged optimally with both ends of the ossified metaphysis clearly visible. The longest axis of the ossified diaphysis is measured. The angle between the femur and insonating ultrasound beams are between 45 degree to 90 degree is typical. Plane 16, then 3 bones of both legs, both feet, and normal relationship to both legs. So you follow the femur to the tibia fibula and plane 15 to 16, slide, rotate, and angle. Obviously, you have to follow with the baby keeps on moving, you have to follow the baby. And normal relationship with the foot to the legs. That is important. When you are seeing all the bones, all the 3 long bones of each limb, and normal relations with the foot is at right angle to the 2 bones, tibia and fibula. Then you come to 3 bones of both arms, both hands, and normal relationship to both arms. So how will you reach there from 14 to 17? Just slide to upper chest. When you are reaching the side near the humerus or head, you rotate and angle. You will get the hand. So you are getting the hand. Once you get the hand, you go on following till the hand. You may not count the fingers, but you have little patience to see whether the hand to the forearm relationship is good or not, the hand is moving or not, or the hand is. So you are confident. You see the hand opening, closing. So it gives a confidence that there is ruling out some major anomalies. Then we are coming to the face. That is the last sections 18, 19, and 20. Plane 18, the coronal view of the upper lip, nose, and nostrils. So from plane 4 to 18, slide, rotate through the 45 degree to 70 degree and slide. Plane 4 is the transventricular plane. So from there, you slide and rotate through 45 degree to 70 degree and slide. You will get the nose lips. So slowly slide and rotate. We are getting the nose. We are getting the nose. And lips, both the lips, chin, we are getting them. So you see the nostrils. You see the upper lip, whether it is complete or not, if there is a cleft lip, lower lip, and chin. You can see the nose in the coronal section. When we are seeing the opening and closing of the mouth, it is much more convincing to rule out a cleft lip. And plane 19, both orbits and both lenses. Again from 4 to 19, slide and rotate minimally. You will get this slide and rotate minimally. You will get the orbits and lens. So you can see the coronal section, both the lenses should be transparent. In transverse section also you see the orbits, and roughly the distance between the orbits, roughly you can accommodate another eye in between these two orbits. That is the normal distance. So if you feel there is a more gap or less gap, you may measure it and refer to the chart to rule out hypo or hypercolorism. Then comes the median facial profile, that is the last section. Again, from 4 to 20, slide and an angle to 90 degrees. Obviously, from head to you are going to median face. Obviously, you have to rotate. You do a angle to 90 degrees and slide with a minimal rotation. You will get the face, median section of the face, or profile view of the face. So we are getting the profile view of the face. What will you see in the face? You will see the nose, both the lips and chin. You can also see the nasal bone here. If you want feel it is less hypoplastic, one measure it and refer to the chart. Here also you can look for the premaxillary triangle. If you move your probe to the mid coronal section, you can see the triangle which is formed by two nasal bones on either side. The triangle is formed by the two nasal bones. The base is formed by the premaxilla, which rules out anterior cleft palate. And also by transverse section, if you are angling the probe from below, you can see the alveolar ridge below this, and any different, you can also rule out the anterior cleft palate by that view, transverse view. Then that's the last sweep, transverse sweep of the body from neck to sacrum, one vertebra at a time. So you start from the head, move till the sacrum. The baby keeps on moving, so you keep your probe, and what you are seeing? You are seeing the skin line and 3 points. One is the vertebra, body, and two lamina, forming a closed triangle. You are following it up to the bladder, up to the sacrum. You are seeing the bladder. So from this 20 plus 2 planes and abnormal appearances, you can rule out all these 50. This is a long list, 50 abnormal appearances. What is the criteria of reference? So any plane, any area, any appearance which does not look to you normal, you should refer to the patient. And in the measurement also, if atrial lateral ventricle is more than 10 millimeters, one or both renal pill is more than 7 millimeters, and all the biometry, BPD, SC, and FL, if it are outside the normal range of the side chart, meaning it is below 5th centile or not above 95th centile, you always refer. How will you calculate the DD? From this biometry, you are calculating, comparing the LMPH, LMPGA, or menstrual age with the ultrasound GA. If there is a difference of more than 10 days below 20 weeks and more than 14 days, 20 to 24 weeks, you always correct the EDD and take the ultrasound GA as your reference point. Then look for the environment. Look for 3 things in the environment, that is cord, placenta, and liquor. For the environment of the baby. In umbilical cord, you look at 3 places. You look at the abdominal insertion. You look at the placental insertion to rule out any velamentous insertion of the placenta, or also you look at the 3 lobes of the cord. You can also see a cross section of the cord which gives a Mickey Mouse sign, which tells you that there are 3 vessels in the 1 artery and 2 vein, gives a Mickey Mouse sign. Then the placenta, you look for the substance of the placenta, distance to the lower margin of the placenta from the cervix, and retroplacental area. That's the normal retroplacental area of having the venous complexes. So if it is disturbed like this, if there is multiple lacuna, you must rule out placenta eclatal disorder, placental eclatal disorders. Then look at the liquor. In this mid trimester, it mostly be a subjective assessment. We look at the liquor to see, in this case, we are seeing good amount of liquor, whereas in this case, we are not seeing any liquor around, very less liquor. So it is oligohydramnios. And if we are going to do an objective assessment, we are usually doing a single deepest bucket method where we measure the longest deepest bucket in the area, which should be between 2 to 8 centimeters. Then look at the fetal activity. When you are doing the ultrasound, always have an eye on the fetal activity. Normal fetuses typically have a relaxed position and so regular movements. There are no specific movement patterns at this stage of pregnancy. Temporary absence or reduction of fetal movements during the scan should not be considered as a risk factor. Abnormal positioning or unusually restricted or persistently absent fetal movements may suggest abnormal fetal conditions. Then cervix, the maternal cervical canal can also be measured, preferably with an empty or near empty maternal bladder. Usually, when we are doing a transabdominal sonography, we do a eyeballing. If cervix looks normal, we may not measure it, but it can be measured in transabdominally. Although the ideal is to measure it transvaginally, but due to discomfort, all mid-trimester scans we do not ask the patient to do a transvaginal for the cervical length. But if she is a high-risk patient, suppose she has a preterm labor, threatened abortion, or during transabdominal sonography, you are seeing there is a dilated cervix or there is a inverted Y, or you say you should measure the cervix transvaginally. Uterine fibroids and adnexal masses should be documented if they are likely to interfere with labor. The application of color Doppler techniques is not currently recommended as part of the routine second trimester ultrasound examination for uterine artery or umbilical artery Doppler. There is insufficient evidence to support universal use of uterine or umbilical artery Doppler evaluation for the screening of low-risk pregnancies. But color Doppler is ideally should be used in case of to see evaluate the heart. Reporting documentation of findings in each steps should be taken to give a customized report. So the key points are working through the 2 overview planes and 20 planes in the described sequence provides a logical, time-efficient examination of the whole fetus. Examining the fetal anatomy correctly is more important than the order in which it is assessed. That means you need not go in order. You do a opportunistic ultrasound. Suppose the baby keeps on moving. Suppose the baby is in prone position or supine position. Prone position. So what you are seeing here, this you are seeing spine very clearly. So you should do a spine first. Well, if the baby is facing up in supine position, you should do the head and face first and go for the other structure, because the baby may move after some time. You may not get a satisfactory picture. But you should have a checklist. At the end of the ultrasound, you must see whether you have seen all the important structures or not. And your role is to distinguish between range of normal and abnormal appearance of the mid-trimester fetus. Any appearance which you cannot confirm as normal should be referred for a more experienced opinion. So, although many malformations can be identified, it is acknowledged that some may be missed even with the sonographic equipment in the best of the hands, or that they may develop later in pregnancy. So you should also tell the patient about this fact. And Dr. Hasmukh sir asked me to show some abnormal pictures. I have taken a few 8-10 pictures just to show you. So you are not seeing any cranium here. There is a crania. When you are examining the spine, you are seeing a spinal defect in the sagittal as well as the coronal sections.
So I think with this, you have to just show, at least you should know that, yes, there is some abnormality. If you are able to know what it is well and good. Otherwise, call a colleague, ask them for help. If still not solved, then refer the case. That's the idea. Yeah, Rajesh sir, go ahead.
So here you can add a triangular sign, but you can see you separate in the transfer second. You are seeing the vertical body and two laminar making U, not a triangle. Here you can see the defect in the occiput, is the encephalocele. In the brain, you are seeing a holoprosencephaly, fused ventricles. Your shape of the head is lemon shaped. You can see the cerebellum, which is not normal shaped, it is banana shaped. In heart, we are not seeing the crux here, it is not closing, so it is a defect in the crux. So you are seeing the heart. Beyond the heart, you are seeing a lot of fluid. There is a significant pericardial effusion. The lungs, we are seeing, you compare the both lungs, one side of lungs is enlarged with more hyperechoic. The lungs pathology. You can, in the transverse section of the thorax, you are seeing the heart alongside the stomach. There is a stomach. In the abdomen, you are seeing multiple cystic structures. There is the intestinal obstruction. In the cord insertion area, you are seeing a projection. Something has come out of the abdomen. To which the apex of the cord is inserting. This is the impulsile. In the abdomen, cross section of the abdomen, you are seeing fluid, typical of a ascitic fluid. Kidney, it is enlarged, you are seeing multicystic kidneys. Enlarged kidneys is multicystic. And last, you can see the single umbilical artery. You want to see the bladder, but one side of the bladder, you are seeing the umbilical artery. And shape of the femur, shape of the long bones, that is it is bowing, it is not normal. And rotation of the foot, you can see when you are seeing the two bones of the tibia fibula, the foot you are seeing at the, you should not see the toes like this flat foot, you should see the sides of the foot at right angles. So it is a rotated foot. So these are the few cases. With this, I end my presentation. Thank you for everyone for a patient hearing.
Thank you very much, Dr. Rajat. You've done more than full justice to your topic and explained so beautifully all the planes with all your very relevant videos. It was indeed a very good learning experience for all our specialists. And I think they must have benefited quite a lot, and they must have gained what are the different issues they had addressed in the pre-poll questions, and so that they can improve on their post-poll results. Now, I would request anyone who can unmute and ask questions, and Professor Hasmukh, Dr. Hasmukh Lal, also you can give your comments now.
Yeah,
and
I think
Shrikant has sent one anomaly video to me. Shrikant, hello. Well, when people are waiting, you can show your video in your screen. Can you show, or shall I show it too? you show it, this huge fetal ascites, and you can see all the abdominal organs hanging. So we have two great experts here, Dr. Hasmukhlal and Rajat. They can give their opinion. Shall I show Shrikant's video? देखो Can you see? Sorry. Is this better?
ନାଇଁ ମ୍ୟାଡାମ ଏଥିରେ କହିହେବନି କିଛି
ନା
କିଛି
ମ୍ୟାଡାମ
ଜଣା
ଦେଖା
ପଡିବନି
ଯାଉନି
ନା
better to share
better to share, yeah, I think.
Then, from what I can decipher, there's huge fetal ascites.
Yeah.
The heart and lungs are normal. Anyway, let's go to the questions.
Yeah.
We
Can I say something?
yes, please do.
See, the point is anomaly exists in only 5%, 4 to 5% of the fetuses, but 95% or 96% may not have anything. So for them, but then what happens is it is important for us to go in a very systematic fashion and identify anomalies in those 5% of cases. And for 5% of cases, you have to look to 100 cases, you know. So that's the thing. So don't be afraid of, and many things will come as repetition, especially the heart. I think Dr. Preeti Dubey is talking very elaborately on heart, and every like face there is a special presentation by Rama Manjari, I believe. So every organ now will be presented whether it is normal or it is not normal. So don't be worried and don't get just disturbed because a lot of things, let us say when we don't know something, we think that, oh, it is difficult, but it's not difficult at all, because when you go in a very systematic fashion, many things will appear that we know what is a normal looking abdominal circumference. So definitely if something which is not looking normal, we will always know. It is like a puzzle, you know, in a puzzle, something where they say what is missing in this, there are two houses. So we can already identify, okay, this house, the second house doesn't have one of the windows is missing. So it's a very simple structure. So don't get upset or don't get disturbed. Take the probe and start scanning. Take the probe and start scanning, and you will learn by yourself. And when we are coming on site, we will tell you the probe movements, how, let us say if you want to go to abdomen, right? If you want to look at the stomach, we know that the plane 11 is the place. So just put the transducer there and you are at the right spot. So point is, instead of doing randomly moving the transducer, if we follow these 20 planes approach, you know, then our scan we can complete. You can see, let us say you have 20 cases or 15 cases in the OPD. So you can do it very quickly because you know the steps, you know where to look at. If you want to look at the face, I am here at the axial section. I rotate 90 degree, come to the front. This is mid sagittal. So it's a probe movement. You yourself will be knowing each and every movement by yourself. It's not difficult at all. I think we will help you when they are coming on site. Thank you so much. And Dr. Rajat, you have done a wonderful job. I really appreciate. You put a lot of effort in preparing those slides. And thank you so much.
Very good.
Yeah.
So
Thank you, madam. Thank you, sir. Thank you.
Okay, there's a question. What is the measurement of cisterna magna?
10 millimeters. Maximum limit is 10 millimeters, up to 10 millimeters. Just to remember 10, that is cisterna magna is 10 and lateral ventricle is 10. So
in which situation does the cisterna magna increase? Because decrease in cisterna magna means there is ventriculomegaly and this cerebellum is losing its
When the
shape.
cerebellum is pulled backward, you want to say
Yes.
increased or say decreased? But
Spina bifida, that space, that fluid goes down and that space is decreased.
obliterated.
Obliterated.
Cerebellum is pushed backward, so cisterna magna is obliterated.
So my question to Rajat sir and Hasmukh sir is I'm putting myself in a very heavy, crowded OPD, PMSMA day when you're doing a scan and what, how to go about it when you have to do so many scans in a short period of time. Is there any shortcut or should we go exactly as 20+2 planes in every situation?
I think
No,
there
what
is no
Quite a long
shortcut.
time.
No,
I
what
think
I was
so.
telling madam, we should do a opportunistic ultrasound. Means whatever seeing first, we must record it first, so that the time spent is less on the baby. So suppose we are seeing the face first, we must record the face first before the baby moves. Heart, we are seeing the heart first, spine first. So in that, if we are doing a opportunistic ultrasound, we will reduce the time spent on one ultrasound. But ideally, we will try to see all the planes of 20+2 planes in the mid trimester to rule out an anomaly. And I think if we are spending a average 18 to 20 minutes maximum, so we can cover the all. If the baby is in a very good position, within 5 minutes also it can be finished. Moving
Yes.
well, very good position.
Yes. That means the more we go systematically every time, our speed increases and our eyeballing is also can capture different aspects. So what is normal is first should be there in the mind. So look for all whatever it is, whatever is normal, and when it is not normal, you can take some time there and pause and see that in detail. So once you see the spine, very quickly you can just cover it. Spine appears normal. Then the transventricular thalamic planes, cerebellar plane come down. So then, of course, what are the images that you should preserve? If it
I
is
think those standard images which we are going to give, it says all about everything.
yes,
Right.
that will actually reduce the anxiety of those who are learning right from the beginning. So we are giving these three first trimester, second trimester, and third trimester scans, normal scans, which will be there put up in your OPD in your scan room, and you can just compare your pictures with that and see whatever is not normal. So Shrikant Sahu, yes, that one. Shrikant Sahu wants to share screen for some time. Can we allow him? Sambit sir?
Sure, sure.
Shrikant, you want to share screen if you can to show your anomaly? I can see there's a huge fetal ascites. So if you can show the detail of your video, we'll allow you some time. In the meantime, any more questions from anyone?
See, I would say a few. I will add something to what Dr. Rajat has said, that sometimes it happens that we are not seeing some structure very well. So we always recall the patient. We can always ask them, okay, come tomorrow, we do it, but let us at least do a proper scan evaluating everything. And as we do more and more scans, what happens is we will be able to complete the whole scan within a very, very short period of time. This is also very true. And like sliding movement itself, if you are sliding from here, one slide from here to here, if you go very, very, very slow, I think we can almost see that, yeah, we will stop if we see something abnormal, but normal looking structures, we can always identify and proceed ahead. So that is one way of doing things in a very, very system. But sometimes the baby's position, or sometimes there is oligohydramnios and you can't see very well. So there are difficulties. It will always be there in, as I said, for in 5% of cases, you will always be having some kind of situation where we would not be able to, even at this stage, I also have problems sometimes, even I can't do that. So everybody will have that. We can't come to a final diagnosis 100% of the time. So don't worry, but at least you, in those cases which are normal, there try to make a scan complete, at least look at everything, and it can be done very, very quickly. Thank you. Yeah. So Srikant Sahu, can you?
Yes, and if you can't remember the planes, you can have a chart up in your scan room so that you can follow one by one. Okay.
But that is available on the internet. Everyone can download it.
No, in the scan room, no, when you're in the scan room, there's hardly any time to go to the internet. So all
And they
these,
download it and keep it in the scan
yes,
room.
all these PPTs have been given, and they can put them in. Let's see if we can make them from our side, and ask the state to, the government to supply it to the different FRUs where they have. And we are lucky that we have two good machines, the G Logic F8 and Samsung HS40. They are two standard good machines, luckily. And so let's have a look at Shrikant's video. There it is.
I'm unable to find the file, madam.
Huh?
I'm unable to find the madam.
ଆପଣ WhatsApp ରେ ପଠାଇ ଦିଅନ୍ତୁ, WhatsApp ରେ ପଠାଇ ଦିଅନ୍ତୁ ଆମମାନଙ୍କୁ। And
Oh,
don't-
madam.
don't
ମୁଁ
lose
share
time,
କରିଦେବି,
don't lose time।
ହସମୁଖ ସାର୍ଙ୍କୁ ଦେଇଦେବି,
ହଁ।
ରଜତ ସାର୍ଙ୍କୁ ଦେଇଦେବି। ଏଇଟା
ଆମର
there seems to be a huge fetal ascites with the liver and the intraabdominal structures projecting into that ascites. But that video should be comprehensive. It should show all the other areas. Okay, now shall we have the post-poll questions? If you have no...
Yes, madam.
Don't worry, Shrikant, I'll share you have Hasmukh sir's WhatsApp number, you can share. You can give it to Rajat sir also. Yes, Sambit, can we have the post polls now? Please don't leave. Attempt the post polls. Don't be afraid. See how much you have gathered, because that will give you stimulus to learn. We are not experts at all. In every presentation, I'm far from an expert, and I feel lucky that I've been able to coordinate this kind of program with such stalwarts, and I'm learning from them at every. I learned from Rajat today a lot many things, and going sliding is so smoothly. He did the sliding and brought the different planes, especially of the face and eyes and all those things. Sometimes it's very difficult, especially if the fetus is moving. But we got a very nice view. So please, we'll launch the post poll now, and please all of you attempt that. Sambit, post poll karo. Then each of the questions will be discussed one by one. Thank you, Rajat, again for a wonderful, excellent presentation.
It is with your blessings, madam. Whatever I have.
Jagannath ko dekhe jo usi chhad de badhiya.
I still remember, madam. You are the first person who had taught me in the OT how to put on gowns, how to put on gloves.
Did you get a blow from me? No, I don't think you were a very obedient and polite student. No problem. Okay, the post poll, Sambit. Sambit, let's have the post polls. People are going out. Going away. Please don't leave. It is in your own interest. Let it be a wrong answer. We won't know whether you have answered wrongly or rightly, but we will get a general poll.
Madam, post orientation poll questions launch.
The post poll are launched, and if you have listened to Rajat sir and Hasmukh sir very, very carefully, I think you will definitely improve in your post poll. You will know your own improvement. We will not be able to know individually. So don't worry and don't be afraid. Nobody will know who you are.
अच्छा डॉक्टर संबित आपण असंती
संबित
हेलो आगे आगे
हाँ मो डीएफडब्ल्यू को पठे देली रिक्वेस्ट लेटर
आगे
हला अस्वास रे पठे देली डीएफडब्ल्यू सारे कथा भी मही जाईची
आगे
फाइनल लिस्ट ऑफ पार्टिसिपेंट भी पठेइची हम सार को लिखि भी देइछु मैडम को पचारे कि ना जे से डायरेक्टर हमर फंड मैनेजमेंट भी जदी किछि अछि से कोऑर्डिनेट करिवो ऑल पॉसिबल सपोर्ट विल बी इम्पार्टेड बाय डीएफडब्ल्यू टू सीओई मैटरनल हेल्थ एंड यूनिसेफ
Thank you very much.
हाँ मैडम सर मैडम संगे भी कथा हेगली मैडम भी एश्योरेंस देइछंती आई विल ट्राई माय बेस्ट टू जॉइन एट लीस्ट फॉर 10 to 15 minutes during the training.
Yes, and we will arrange the inaugural session to madam's time.
हाँ
When madam comes, we will have the inaugural session at that time.
हाँ मैडम को शेड्यूल रे मु रखी देछि मैडम खाली
3
टाइमिंग
PM. What is the likely time that she is to come?
मैडम कहले मोर सकाळे गुटे मीटिंग अछि if I get time I will be there by morning session or else म आफ्टरनून रे जिबली कहछन
Better afternoon रे असले भलो.
ठीक अछि मो फाइनल करी कहबी मैडम
रिसोर्स पर्सन आ जेथिबे तो
मैडम आ गुटे कथा मैडम कहले मैडम
हां
मैडम कहले जे गुटे बैकग्राउंड डॉक्यूमेंट देबा पई
कोन
बैकग्राउंड डॉक्यूमेंट ए जो ट्रेनिंग ता हबो से ट्रेनिंग रो पर्पस कोन बैकग्राउंड डॉक्यूमेंट टी ताको दरकार वन पेजर
हो मु दे देबी
हां दे देले मैडम को दे दे से पढिबे ना जानिबे जिंसडा आगे
मीना
डॉक्यूमेंट वन पेज दे देले
मीना सोम
हां दे हां कहि दियंतो मैडम हां मैडम को कहि दियंतो खाली गुटे पेज दे देले मु मैडम को दे देबे से
हो
मो लेवल रा मैडम काम सरला बर्तमान डॉक्टर संबित कर टिके काम अछि
हां
मु से लिखि मु स्पेसिफिकली भी लिखि देछि एमएस डिवीजन एंड एसटीसी सीनियर ट्रेनिंग कंसल्टेंट एसएमसी सेल मे बी डायरेक्टर टू कोऑर्डिनेट ऑल द एक्टिविटीज बोली भी लिखि देछि मेल
क्वेश्चन 1 रे काई केते कंफ्यूजन होउची तमे आउथरे देखो all are true of 20+2 planes except which one of them is not true except टा चूज करो Question 2 tactic. Question 2 everybody has understood. हाँ जमा 7% काई पार्टिसिपेट करचंती समस्त पार्टिसिपेट करो आमे तुम जानि परिबु नहीं तुम निजर भूल पछे करो and wait till the questions are discussed. If you leave, you will not be able to know whether you are right or you are wrong. Please don't leave. It is in your own interest. Answer the questions and wait, because every one of the questions will be discussed. And why the correct answer is correct will be told to you. So how will you improve otherwise? This is a design which has made to improve your knowledge. First is your concentration power, whether you have listened to all what was presented in by the speaker. So
Don't leave, because when we are answering the
nobody
questions,
will know whether you are wrong or right, but
I am
you
going to-
yourself should know what is right. No. So please wait, because Hasmukh sir will discuss each one of the questions and why the right one is right. Don't leave. If you are foolish like the gynecologist Archana, what was her name? Sharma, who committed suicide. It is a foolish thing. So if you don't answer, it is foolish. You will not improve your capabilities. Please answer, whether you have understood or not. Again, you answer whatever you think is correct, and then wait to know what is the correct answer. You have to wait. 88 जन थिले 73 को कहीं ड्रॉप कलो तने कोन लाभ होची अटेंड करी जम्मा 17% कहीं अटेंड ये करछो. Be bold. That means you don't want to learn. और आसी के पार्टिसिपेट करे लाभ कोन हैला. तुमको ऑनलाइन रे people had doubts, even the DFW had doubts ऑनलाइन रे कोन से माने सिखिबे, किंतु ऑनलाइन रे जे केते सिखि होउची तापर आमे केते समस्त जो 16-17 जन से माने रेडी हे चंदी तुम बापू जाई के सिखेबे ता पूर्वरो तमे निजे को प्रस्तुत करबोनी. Don't leave. Answer and don't leave till the questions are told to you, the answers are told to you. It is unfair. So much of interest is being generated, effort has been put in for your learning, so that women and children, women and fetuses will be safe in your hands. That is why all this effort. तमे स्कोप पाई नथलो इंप्रूव करिया पई, तमे एकदम बिजी शेड्यूल भितरे पाउ नथलो केमिति कोन सिखिबो, जंत्रटा धरि के आबु जबरु करिया अपेक्षा तुम केते सिस्टमैटिकली तुम पई इशू ऑफ गाइडलाइंस हसमुख सर आनी की पहुंचेले, गोटे पर गोटे एक्सपर्ट्स तुमको बुझौचंती. बिफोर प्रेजेंटेशन कोन तमर बैकग्राउंड नॉलेज थिला, आफ्टर प्रेजेंटेशन कोन तमर नॉलेज टा इंक्रीज कला, इंप्रूव कला, तापरे पुनी प्रत्येकटा रो आंसर भी तुम कहि दिया जिवो, ता भी तमे वेट करबनी. हां, कम ऑन, बी बोल्ड. एते डरुआ कें हबो, इति जदी डरिबो तमे यू आर चीटिंग योरसेल्फ, यू आर चीटिंग द पीपल. हां, जहाँ आंसर कर पका समस्त प्रत्येक क्वेश्चन रो आंसर करेक्ट आंसर तुमको कहि दिया जिवो या पर. एंड यू प्लीज वेट, डोंट लीव, because if you leave you are a coward, and because we know we won't know that you are a coward, it will be you who will be the coward. ना मैं एक्सपर्टीज इंक्रीज करबा ना, नले एमिति करि के मा छुआ को मारुथुआ बस. हां, Hashmukh sir is 76. Just look at his age and how much he has dedicated to learning. Just look at Rajat sir. Rajat, how much he has put in effort to learn and increase his expertise. तुम एक्सपर्टीज इंक्रीज कले तुमको पई रिकॉग्निशन आसीबो ना रिकॉग्निशन पई नो एटलीस्ट इफ यू डू योर जॉब वेल इट इज द बेस्ट सर्विस टू ह्यूमैनिटी एंड सर्विस टू गॉड डोंट लीव आउ दी जण छाडी पळेले आउ दी जण कावाड छाडी पळेले दी जण कावाड छाडी कि पळेले जानिबा पई रहिले नाही कोटा ठीक आंसर दिस इज cowardice तमे you can't make a you can take a horse to the pond but you can't make it drink तुमको नहीं किरी जाउचो पानी पीवा जगह को तमे पानी पियो को रिफ्यूज करूचो you are cowards तमे पळौचो जो तम जे पळौचंदी सेमान होचंदी कावार्ड तुमको तमरो एफिशिएंसी बढ़िया पे एते प्रस्तुति एते ऑर्गेनाइजेशन करा